G'day. Welcome back to the Sports Medicine Project. I'm your co-host Blake with my other co-host. Welcome, Kelly.
Welcome.
How are you doing?
I just welcomed myself.
Yeah, you can do that. It's your
but I'll
podcast.
welcome you too. Welcome to the podcast.
Thank you.
Happy Sunday.
Yeah, Sundays are good for us. I really wish maybe we should try and do this on a Saturday instead of a Sunday, because I do think it's good to do at particular times of the day. And what I'm reading at the moment, I'm reading the book Noise by Daniel, can't think of his last name, but he's talking about, and he speaks about in all professions, but definitely the health profession and the medical community, and all the research has been done in judges, but he is saying that if you are someone that works in a position where you are communicating with other human beings, or you're offering a service, it requires skill and memory and cognition, to believe that your ability isn't going to be affected by such things as like the time of day and the mood and the context, that he thinks you're full of yourself.
Yeah, I'm fully aware of that.
Yeah.
My hour is the morning. Up until like 3, I'm pretty good.
Yeah.
Anything beyond 3, it's on the gradual decline.
Yeah, it just makes you think. I mean, you see people, I don't know if you feel the same, but sometimes when you have an initial, very late in the afternoon, sometimes it can feel like, oh man, I'm really going to have to pull a lot of mental energy for this. But then it actually is fine. Like once you start it, it goes okay.
Sometimes that first patient after lunch is tough. Like getting back into it straight after lunch. I feel like that's a... Like you got to really get over that little bit of a hump there.
Yeah. And yeah. Especially because you only have half hour. Hey, we have an hour for lunch. What do you think's the best? Because I've done both. I really love the hour. Coming to work where I am now, we have a full hour, and it gives you, what I really enjoy is it gives you time to run late. And not to say that you should run late, or that's always the case, but it can be helpful if you really want to spend time with someone, or perhaps someone like myself, we see people from out of town. They might come from, say, Port Macquarie or Gloucester or Scone. Had someone from Tamworth recently, and I intentionally put them in a certain part of the diary. So I'm like, I can run late because I want to spend more time with you because you're going to be away. But it gives you that ability to run a little bit more. Do you find that? Because are you 30 minutes or an hour?
30 minutes for my lunch break.
Do you think that's...
But that's even enough time for me to get a little bit like tired and lose my momentum. I'd rather go like 7 hours straight, I reckon.
No way. Yeah.
I don't know. I get, maybe it's a mental thing, but as once I've like stopped and had a little bit of a break, I'm like start to get a bit sleepy. Whereas if I'm just like back to back, get the momentum going, like the Knights in the back end of their season. I'm pretty good.
But what happens when because you're going to run late? We're in a business where things are unpredictable. People are going to potentially mention things they didn't mention before, or right at the end, or they have a question, or you need to spend more time with them and you're going to run late. Do you think you'll be able to, I guess maybe because you're a lot more organized, you're a lot more efficient.
Yeah, I probably run less late than you, I would guess.
Yeah.
Just off knowing you.
Yeah.
I do run late though from time to time. I can catch back up as well though. Like if you just kind of finish up with people like 2 minutes earlier, then you kind of make up time. I've worked out.
Yeah, yep, depending on it. And not everyone's a fool.
Again.
Yeah. I just... And maybe that's just what I think is important. Doesn't always mean that the person that I'm trying to help isn't going to perceive that. But one thing I've been really trying to work on the last couple of months is just trying to have my notes almost finished by the time. And I know that's an efficient way, and I know that's more sustainable, and I know it's better long-term, reducing burnout and things, to try and have your notes relatively done by the time I walk out, or by the time it's to lunch break. So you just got to fill in a couple of things.
And see, even that I'm better at when I'm like fully back to back. Like if I know that I've got no time to write notes, then I just get it done in like 10 seconds between patients, opposed to if I've got like a little bit more time and gaps, or I know that like lunch is coming up, then I'm like, oh well, I'll just write that in my lunch break. And then I kind of run more behind.
Yeah, so I can't seem to, for me it seems to be so important to, like I see so much value when just sitting there speaking. You know, we had this conversation like months ago where you said potentially when you're first seeing someone for an initial, perhaps you don't write things down as they're speaking. You just look at them and listen to them. It's the first point of contact. You want to try and build that therapeutic relationship and trust and like they're being listened to. I probably do that more on the back end. So I'm like, we've just gone over all these things. Say for an example of someone that comes in with Achilles tendon. I'll use an example I had this week. Someone that I saw second appointment for an Achilles tendon, wanting to get back to some running, and right at the end, we just spent 10 minutes, no writing at all, which I could have been writing, just speaking about really basic. This is what I expect to happen, probably with your tendon. It's going to be a longer road. We can probably start some things sooner than what we perceived. Here's a pain modulating stuff. I probably expect you to have some flare-ups. We're not going to have to catch up every week or every 2 weeks. It's a bit longer because rehab takes time, those kind of things. And I really try to have that relationship. And I think some people do value it, but it's always hard. You can't then say, hey, was that valuable for you? Did you like them? So that's why I kind of sacrifice. And I'm like, what's more important? I can do my notes later, but you're here right now. I don't always have the access to do that.
Yeah, and in those scenarios, 100%, I think it's definitely worthwhile skipping on those notes and having that meaningful conversation, particularly if they're engaged and asking questions, because if you're rushing them out the door, they're going to know that you're rushing them out the door. So I never want patients to get that feeling that I'm rushing. And even if I'm, running late, I still don't want them to get that feeling that I'm rushing. Like I want them to feel like they've got the time and all of that. So try to be conscious of that.
Yeah, one thing I think has definitely changed with me is I really looked for if there were any signs from the consult that the person has taken in what I said. And there's a couple of things that you can do. Ask them to say, I say, if you went home and your partner or someone asked you what happened in the consult, what would you say? Or you can just ask them if that made sense or explain it back to you or that kind of thing. But now I've kind of moved to where if someone doesn't understand everything that I'm saying, that's fine and that's expected and that's normal. And especially what we're going to talk about today, which is pain, it's okay for them to have the idea or to briefly think about it, because they're going to have until the next appointment, hopefully think about it more and perhaps ruminate on it more and perhaps come to a better understanding. So I might say that something about your tendon needs load and it's going to feel better after that. And they might not understand it. And I don't really know if they do, but then if they think about it, perhaps they have an experience like, that makes sense. So it doesn't always have to be, they have to get everything that you say in the first consult. And that's something that's been probably a bit less stressful for myself. You ever have that? Like when you were dealing with a lot of persistent pain when we're in the sunny coast, I imagine it's the same thing. Like you're not expecting people to understand what's happening with them then and there on the consult, but it might take 3 months or 6 months, or perhaps they never get there, but perhaps they do get somewhere closer and that helps them.
Did you have an expectation that they would understand that all after the one consult?
No, I didn't. I probably never thought about it as much as what I do think about things now, but I definitely thought that, they should understand it. You should understand what I'm saying, and I'll explain it many different ways. And if you do, that's really good and that's helpful. But now, and I would look for ways to see that was the case. But now I'm like, that's completely, it's fine and very expected that you won't, but you'll perhaps have that happen over time.
Which is probably leads us to what we're going to talk about today, because I think this is complex stuff that we're explaining to people, and we want to be finding the words to make it as digestible and as simple as possible. So it would be an unrealistic expectation for patients to completely understand what you're explaining to them when it's taken us, like, how long have you... It's taken 10 years that I've been going through physio and then working as a physio, and I still don't understand pain completely, and I don't think a lot of physios or clinicians do. Well, we don't know heaps about it, and it is a bit elusive in some ways. So for us to expect patients to understand it from one consult when they have been flooded with information from other people in the past about something that might slightly contradict what they're saying to them, I think is not realistic. And I think that we'll tie into that a little. Like, I've written some notes about what I want to talk about today and how we can give some practical examples to you guys of how we make that information more digestible, because just sort of explaining it to them, I don't think they take on board so well. And this is so much stuff that I've learned from my mentor Dave, who's my boss at Newcastle Performance Physio. He's a very experienced pain physiotherapist, and he has taught me so much around this topic and taught me in a way that is just gives so much more understanding for people and their painful problems rather than just information, which I think can be not so useful in some ways.
Yeah, I think thinking about it more, probably what I mean is when I would talk about something or try to explain something, and I would do that for hopefully for their benefit, and we have some research to say that when people understand what's happening with them, things can be a whole lot easier, their quality of life can be better, although the pain and function may not change. But I think I felt like I wasn't doing anything so let's say I was to explain something that was happening, which I think that would help them, and perhaps if they didn't understand it, I'm like, oh man, I felt like I haven't even really done anything, because it hasn't actually helped you yet, but it might in 3 months or 6 months when you understand that. So saying like, oh, cramp. Oh, my doctor, in the long run before this. I'm trying to practice that position.
It's just your nociceptors.
Yeah, but we'll finish with this point and then we'll get into it. I meant as in, you really do want to, and we're in this business per se to help people, and it can feel like if we could say that them understanding is going to help, and then perhaps they don't understand it then and there, and they're not going to be on 3 months. Well, it's like, how much is it going to help you now or in the next week or in the next 2 weeks? So it feels like I haven't done anything. That's probably what I meant. But now I've come to the point, it's like that's okay. That's how long these things can take. And we don't ever do just one thing. It's a combination of things, and how much it might help having a little bit of an understanding. We don't really know. Which is going to lead us to our topic, which is what we're going to do today is show you how to use pain, just another tool in the tool belt. No, I'm only kidding. That is not anything what this is.
How to use pain.
Yeah, how to use
pain. Use pain as a
use pain science.
Technique.
It's just like manual therapy. You just use it and it works. No, but I say that joke because I originally thought like that when I very first discovered it.
I used to write in my notes, in my treatment notes.
Did pain science.
Explain pain.
Yeah. I used to think, sweet.
Explained pain.
Yeah.
I wrote.
Like, I'll just give you this analogy about, it's just sensitive. And they're like, oh yeah, Blake said it's sensitive. And it's like, bang, they just don't have any discomfort.
And then I've like asked patients before, I've been like, has anyone ever actually like explained pain to you?
Thinking just like this weapon clinician.
Like revolutionize their
sit back for this, because here it comes. Here comes the pain.
And then I try and explain it to them, butcher it completely, and they're like, fuck this.
Yeah, and you're like, yep, makes sense. And because everyone just said, yeah, it does. And you're like, oh, sweet, you got it now. So you just expect them to just walk out the door going, oh, yeah, that analogy about fuel lights and my nervous system is sensitive. This pain isn't real, I think. But what sparked this conversation is I'm currently reading the second edition of the Explain Pain book. Now, Kelly's done the Explain Pain weekend course, and she said it was incredible. Before we get into any of this, we really highly recommend to do the course or to go and buy this book by David Butler, Lauren Mimosa. There's heaps of contributors, but it's awesome. Only 50% through at the moment, and it was, when we were sitting on the beach and I was reading this book, and I just tap you all the time. Like, it's relatively, it's newer for me because I haven't read it in this context this much, because I might read it in the context of a research paper or hear it, but you've done the course, so it's not as new for you. But it is really, really interesting and explains a lot.
Mm-hmm. Yeah, I read this book in uni because
really?
The end thing. I can't remember what it was called.
The OSCE? Viva.
Yeah, the oral defense.
Oh, yeah. Oral defense. OD.
One of our cases was a chronic pain case, so I read the Explain Pain book. That was the first time I ever read it, just to try and help with that.
That's
preparing
wild.
For that.
See, we didn't have anything in the curriculum at all. I remember explaining my very, very, very first mentor. They didn't know what Explain Pain was, or just the whole multifaceted nature of pain. And I think I'm pretty comfortable saying this. I think that people in the podiatry profession might agree with me. Not to say this is everyone in any case, this is just my experience, but our profession is built kind of on that kinesiopathic model, and that's okay, that's awesome, because we understand biomechanics quite well and anatomy, but this whole other side to things is at play the whole time and is always happening, and we need to have an understanding of it. And it makes so much sense. Not to say this is for patients and you go and explain this, but it makes so much sense why our mechanical treatments aren't that effective. If you look at the research, our mechanical treatments are not that effective.
Do you remember your first glimpse into realizing how complex pain was? Like, do you remember that moment in time when you're like, oh, fuck, this is actually really complex and confusing?
Yeah, I do, because I remember thinking to myself, how just silly. I felt embarrassed.
What was it? Can you explain it? And then I'll explain mine.
It was definitely when I was at Sports and Spinal, and there was Sophie Stewart. She was another person who probably was the first mentor I had that really explained this kind of stuff. She wasn't a direct mentor, but I would speak to her about this stuff. Yeah, she was awesome. And I used to sit in on her consults, which was awesome as well. And she, it was funny because she's older than me, but she knew what I was like. She knew I was a podiatrist, very kinesiopathic. I explained a lot of my treatments very kinesiopathic, which basically just means I believe the biomechanics was the sole contributor to everything. Flat feet, I can tell the femoral rotations, all that kind of stuff. And we were talking about things, and she would never ever make me feel bad. She would just ask me more questions, and then I remember someone had lateral foot pain, and I made them a lateral wedge, and they didn't get better. And I was talking about this with her, and I was just like, why isn't that working? I'm unloading the tissue. It should be feeling better. They have the biomechanics that makes me think that this orthosis would be more effective. And then I kind of asked her, and then she explained it. A little bit of like hypersensitivity and why mechanical treatments aren't effective. And I was just like, fuck, you're absolutely kidding me. This has been happening. And then I just had I was almost embarrassed, because I thought to myself, fuck, how can I think that I was that good and knowledgeable and I just knew all this biomechanical stuff and it wasn't actually happening? Or I didn't know that was happening, and nobody really kind of knows. But that was
I remember that, because then you got really into the word no CB.
Yeah, no CB.
You're just using the CB for everything.
Yeah, I was.
My first glimpse into the complexity of pain was in my third year placement. I was in a hospital placement.
Oh wow, so you're in uni.
Yeah, and we had to do a presentation, and I was like, oh, I'm going to do a presentation on pain. Like, that's the main reason that everyone comes to see us, is because they've got pain of some sort. So I'm just going to do a presentation on what pain is, and thinking, I was like, this is just
10 minutes so simple. Max. Yeah.
And I started looking into it, and I was like completely overwhelmed. I was like, I cannot talk about this. This is just insane. And I abandoned that topic, and I think I did it on something else because it was just so overwhelming. And then from there, it just cascaded, really.
Yeah, that's how it went. It's interesting. It really is. So I think to preface this, but we wanted to say what we think it is and why we think it's important. It's interesting to understand, because it gives some reason as to why some treatments don't potentially help or work as well as what we think, and that may be purely from a clinical experience point of view, but also in the research. And why, although tissues can heal and look to heal on imaging and can go through the normal tissue healing timeframes, people can still have discomfort and pain, and people can have pain for a really long time. Treatments that should help don't. Helps a little bit understand why that is, and to try and understand a little bit of the neurophysiology of pain, because you're right, people come to see us for that plus, not being able to do what they enjoy. Is it the pain in their knee, or the fact that they can't go out and do the things that they want to do? Do you want to talk about what it isn't? What pain, and what are we going to call it? We'll just say, for the context of this, just call it P&E, which is like pain neuroscience education, which is probably what you'll see. Or maybe just pain neuroscience.
I'll just call it pain.
Yeah, pain stuff. Because I want to shorten it. Because in the content, it could mean so many different things, and people can talk about it.
I'll forget all the acronyms and just end up calling it pain anyway.
Okay.
So, as we already touched on a little bit before, but it's not something that you just go out and explain to people. Like, we've made these mistakes before, and from experience, it's people will, no matter how great you are explaining it does come across as if it is in their head. So I think that it's less about explaining these concepts or ideas or, theories to people, and more about showing them how their pain is changeable and giving them context to their pain and helping them understand their pain rather than pain as a concept.
Yeah.
And this is something that Dave's been so helpful with, because from my previous job, like we used to sit down and do like step by step, like week 1, we're going to talk about context to pain. Week 2, we're going to talk about nociception. Week 2, 3, we're going to, and it just didn't make sense. And it didn't flow nicely, and it didn't help people understand their pain. So I think that what we need to do is use this information and try and break it down and then be able to actually apply it to a person, and that person is the patient that's sitting in front of you that's asking for help and wanting to get better.
Yeah, and I will add that there's plenty of resources and videos. If you're someone that doesn't have access to, someone you can refer to or speak to, or you feel a little bit, uncomfortable speaking at this with people, there's resources. The guys from the NOI group, they create resources for patients to read. Patients could read the Explain Pain book, definitely. I will add to that, I wanted to get your thoughts. You're, definitely right in saying that you don't just explain what it is to people, but there are some contexts where people are ready to hear that, whether they've seen a pain specialist physio or a pain doctor, or perhaps have gone through or read Explain Pain themselves, or they've seen a couple of things online and they do ask you that. I've had it happen a couple of times. Have you ever had that happen? And do you kind of go a little bit more in depth?
Based off a lack of understanding and how it's relevant to them, because they're seeing you for help with their problem. So they have heard of these different ideas and concepts, but they don't understand what the relevance is to them. And I feel like that's what the error is in how some clinicians have approached this, perhaps, is that they've gone through the concept of explaining pain, or going through tried to make sense of like their imaging or whatever it might be, but maybe it hasn't made sense to that person in their context. And I think that's why they're asking you in the first place.
Yeah, and that's the hardest. I had a conversation with someone on Instagram this week. Like, that is the hardest part of this whole idea and trying to help someone, is trying to have them come to the point where it makes sense for them. Mm-hmm. Yeah, so if we just start, which I'm sure everybody has heard, that we have pain for a reason, and we thought we'd start with a couple of quotes from the book, a lot of information that's pretty interesting and pretty understandable, we thought, and then to talk a little bit about it. But you have pain for a reason. Yes, it is unpleasant, but that unpleasantness is the very thing that makes it so effective and an essential part of life. It's the most powerful protective device we have. It alerts you for danger, often before you are injured or injured badly. So it's there for a reason. Mm-hmm. Do you ever discuss that or talk about that with people?
Yeah, so I want to give some like practical examples throughout this. So Blake's gonna highlight the points that he thought was quite useful and interesting, and how that can then, I want to talk about how that can then sort of be applied to patients.
Yeah.
So
yeah, I like it.
I think with what Blake said, like in terms of how you would show a patient or demonstrate that to a patient, you could sort of talk about like how exposing them to movements and activities that have been sore for a long time is actually helping your body to sort of trust you more, so you don't feel the need to react as strongly as you have been. So rather than sort of explaining what Blake just did, which is a little bit more sciencey and perhaps could be misconstrued as what is commonly assumed after pain is explained to people, in it being in their head, you're sort of de-threatening movement and putting reason into why they are moving through pain in some scenarios to help their body to sort of trust them again, if that makes sense.
Yeah, so the context of that is that the thing, and this one I found quite interesting, is, and people will know this as well, you don't have pain in your foot or in your knee. That is not where the pain is created per se. And again, we're trying to simplify it. It is a very, very elevated pitch. You send something, and we'll talk about this later, send something spinal cord to the brain, and then it's if the brain perceives that as a danger or a threat, that is then produced, that then produces pain or discomfort or something. unpleasant. So it won't hurt if your brain thinks you are not in danger. Or that's kind of what they think from explained pain. Is that what you're familiar with?
Yeah, I guess that's not necessarily something that I would explain to a patient, but that's how I understand it in my own brain.
Yeah, I would just give context as well. The idea of the podcast is we know the majority of people that listen to this isn't a podcast for people like patients to listen to, although they might. And as we said, I'm coming more from what the book is saying and for clinicians because I think it's interesting. But I guess we could do a little bit of both, like you said. You're more patient.
But I think clinicians need to, I think it's also important to know how to use this with patients practically.
Yeah.
Because you can go and read Explain Pain and get all of this, but then how do you actually approach a person with pain is different.
Yeah, I completely agree. And I'm not saying that exactly what I'm saying you should go out and say to people, but what I'm trying to, I guess, hope from this is for where you are to say to explain it to people and help them make an understanding of it. I think you need this as a basis.
Definitely.
To be able to do that.
It's the foundation of the iceberg.
Yeah. So like you said, if I kind of speak about it from this context, clinical point of view, and then you come in with the practical example, because you're going to be way better at that than me anyway. Yeah. So, as we all know, the amount of pain you experience does not necessarily relate to the amount of tissue damage you have sustained. It can, though at times, of course, and I find that this one can be harder for people to grasp because it doesn't make a lot of sense. Like if you see an MRI of your knee and it looks healthy and there's no issues or there's no degeneration or there's no cartilage loss or anything like that, it's like, well, why is there I shouldn't have pain there. And then vice versa for if I see my back have degenerative change, I don't have pain, that doesn't make sense. Yeah, do you think that's why it's really difficult? Because logically it doesn't kind of make sense for someone that's not a health professional?
Yeah, so again, I think you can use the patient as an example here. So I would assess them to convince them and educate them that their pain isn't due to anything nasty. So for example, if someone has low back pain and they're concerned about, what could they be concerned about? Let's say I don't know.
Breaking something?
Yeah,
or
maybe.
Flare-ups or something, maybe?
Let's say they're concerned about like a nasty disc herniation or something like that. So if you get someone to try and they've been avoiding bending and they haven't been wanting to pick anything up because their back flared up when they were sort of bending down to get something out of the fridge or something like that. So you could assess them and get them to flex their spine in standing, and let's say they've got pain in that position, but then if you get them to sit down on a chair and touch their toes, if they're able to do that or are able to do it a little bit better or with less pain, then you can use that as a reassuring point that, look, the amount of movement that's happening through your spine is the same when you're doing that from a seated position as you are when you're doing it from a standing position. So if there was anything nasty, we would anticipate that it would be potentially the same in both positions. So it's probably just due to the context or the position that you're in and what your body remembers as that being quite provocative the last time that you heard it like that. So let's try and then the other thing that you can do with that is use manual therapy. So I think in the context of pain management, manual therapy is so useful as helping patients to understand that their pain is changeable. So you could try some manual therapy for that person for 5 minutes and then get them to retest, do the same thing. And if it changed their pain in any way, like made it feel a little bit better or a little bit easier, then you can again use that person as evidence and say, look, the fact that we were able to modify your pain or change your symptoms a little bit from 5 minutes of a little bit of manual therapy is again an indication that there's nothing nasty going on. And what we've done here is just help to desensitize your system, help your body understand that when it is getting exposed to a stimulus that isn't super comfortable, it's nothing nasty and it's nothing that needs to be sort of telling you is dangerous.
Yeah, and manual therapy just fits into the whatever pain modulating tool that you want to use, and of course you weigh up the risk versus the harm. It's not whatever can change we use, and I really do think that's the case with like chronic plantar heel pain and shockwave, or any kind of shockwave, and and tendons or joints or whatever you use it on. I only use it for Achilles and plantar heel pain, but it's just some other stimulus, and like you said, it's changeable. I'll never forget a time where someone had some ankle joint pain when they were doing a single leg squat, and I got them to do a single leg squat, had some discomfort, and then I just grabbed their quad and just squeezed their quad, and they did it, and they didn't have any discomfort at all. And it was just, you do see it, people just like, that's really weird that happened. And say anything or talk about it and just kind of let them think about it, and it's interesting.
Yeah.
The other thing I wanted to add to that, talking about the amount of pain you experience does not necessarily relate to the amount of tissue damage you have sustained. In the context for us, if you've ever had a paper cut, and things can swing the other way. So, when you think about it, and you have one today, not really a paper cut, you thought it was like
I thought my nail was going
2 centimeters deep. But, what is it about a paper cut? It's not deep, there's not that much damage, it really hurts, it stings, it makes you annoyed, and you can't believe that a paper cut could hurt that much. So it can swing the other way as well, where we're looking at how much pain you experience, does that relate to the damage to the tissue, and then vice versa as well, where you can have relatively no, in quotation marks, damage, or a little bit, and the pain can be quite excruciating.
Yeah, and look, I think that this most commonly comes up when patients come in with some sort of imaging or some sort of scans. That's when this kind of conversation is sparked. And I think that if someone is coming in with imaging, you can't discount it. So if you brush it off, then it makes them feel like you're not validating their symptoms and their experience. So I think it's really important to look at their scan, read the report, maybe use it in the cup analogy. So the Greg Lehman cup analogy, I'm sure everyone's quite familiar with the cup. So essentially there's lots of things that can contribute to your painful experience, and maybe the imaging is. So I don't think we can be certain that changes to someone's tissues isn't contributing to their pain in some cases. So I think we have to consider it. And I think that, again, it gives them context to their pain by saying, look, this might be a factor, but all these other things that are going on in your life right now could also be a factor. And then, tying that into, I guess, what their goals are and what they want to be able to do. And that's going to depend on the person and the tissue that they're concerned about.
Yeah. So they talk about how lower back pain and headaches are some of the most common pains in human beings. We know from the lower back pain research, the amount of disc and nerve damage rarely relates to the amount of pain experienced. Many of us have scary sounding disc bulges, even squashed nerves, yet we never have any symptoms. I think it's just refreshing to think about it, because if we understand these concepts, for other people that don't understand these concepts, it can be incredibly frightening. Understand it from the patient point of view. It's very easy for us to say about these things, we don't have any pain, and we understand that we can probably work to get it better, but it's very, very easy for us. So perhaps it does help sometimes to see it from their point of view and perhaps show, more empathy and concern. But it can be really quite relieving when they understand it for their context. And we have the research to say that as well. If people have a better understanding of what's happening to them, perhaps it's not so much that their pain changes, but it's their disability, which there's plenty of scales that they use for that. But disability, quality of life, and those things do seem to be better. So many changes in tissues are just a normal part of being alive and don't have to hurt. What's more is these changes don't necessarily have to stop anyone leading a very functional and active life.
I like the headache example. That's a really good one. That's not one that I've thought much about, but it is true. Everyone gets a headache. It is quite painful. Often people need to have a Panadol, but what is it? What is a headache? No one really thinks. I don't think I've ever seen anyone that's, unless it's a reoccurring cervicogenic headache or something like that.
Yeah.
The one-off headache that you get, people don't necessarily associate that with tissue damage.
It can be incredibly painful. Yeah.
I like that one.
Yeah, and there's lots of analogies that we're going to mention as well, but they really can be effective, and it's even bonus points if you can make that relate to them and their understanding. Or you can use, I almost think like the holy grail is if you can listen and talk, and that's why these consults, they just have to be an hour. Like you can't do this in 20 or 30 minutes, but if you can use an example or experience that they've had, that they've told you as an example as why you need to potentially do this, where maybe they've had an injury or pain in the past and they still did a little bit and then it got better. Like there's no reason why that can't happen now. Perhaps it's just going on a little bit longer, or perhaps it just takes a little bit longer.
Yeah, this is something that I had written in here for a little bit later on, but it's sort of relevant now. I like to talk about pain a lot of the time as it's your body sort of putting up a call for change. So that could be to do more, or it could be to do less. So someone that has an office-based job and maybe they are getting those reoccurring headaches, maybe it is because it is their body sort of asking them to get up, to move around a little bit more frequently rather than spending 8 hours a day in that one position. And then like similarly, if someone's rolled their ankle and they've got a really inflamed, swollen, sore ankle, it's their body telling them that you need to do something different. We can't keep going at this sort of rate if we've got this big inflammatory response. And I think that that's a nice way to sort of explain it, is a call for change. So it's not something scary, it's just your body sort of asking you to do something differently.
Yeah. One of the cool quotes that they use, and it's a little bit of trivia as well, but they just talk about the medications and the shape and the colour and things like that. But people around the world consume more than 100 billion aspirin tablets per year, 40,000 tons. They say if you put them all on a line, the line would be 1 million kilometres long.
Wow.
That's insane.
To the moon and back.
Yeah, that's crazy. So what they talk about is, it's a known fact that the shape of the tablet plays into the effectiveness of the drug. Transparent capsules with coloured beads work better than capsule with white beads, which work better than coloured tablets, which work better than square tablet with the corners missing, which work better than round tablets.
It's interesting. That's similar to that study. I don't know if that got released, the one that Ian Griffiths did about the colour of orthotics.
Yeah, with black and green. I didn't go to the pod conference, but I don't think he has got it released. I'll have to ask him.
Yeah.
But it just, I mean, there is so much evidence, both clinically, anecdotally, both in the research, that pain and these experiences that people have that we are seeing all the time, and this might happen 60 times a week, it's contextual, and there's experiences that have happened previously. I talk about an example in the book of a guy, let's call him Gary. Gary goes to the zoo and Gary gets his nose bitten by a bird. Gary comes home to his family, it's really painful, it heals in a week, but over that week, they're really concerned that, we can't go to the zoo anymore, we can't do it, we're all going to get our nose bitten off, and then the family starts singing about a nursery rhyme, and then it gets passed down through generations that we can never go to the zoo because birds will bite our nose off, and then people get an irrational fear of birds, and then the next time someone has an experience or some kind of interaction with a bird, the pain or the sensation or the sensitivity is amplified because of all these contextual experiences that have been happened prior and previously.
Maybe that's my problem.
That could be your problem.
Maybe I'm related to Gary.
Yeah, maybe Kelly's got a fear of birds. Mm-hmm. Yeah, it could be. But I mean, I've seen photos with your dad with parrots on his head, so it's not your dad or your mum. It's such a funny photo. But like that happening is, yeah, it's. I don't know if originally it used to make me feel like I was like, well then, you had that feeling or that thought, you're like, oh, well, nothing I do is worthwhile then if I actually never know what's working. But then it's like, oh no, that's okay, you get over that, and then you kind of, I have come to realise that that's okay, these things are always happening, and that's happening with everything that I do. It's not this linear system, like you put something into the system and all these things interact and you get an output, and it's not always predictable. Yeah, but I thought that was a good example.
Yeah.
So the point is that pain depends on many factors, and it is the brain that decides whether something hurts or not 100% of the time with no exception. Now, I've heard you say it a couple of times. It is true that it is in your head. Well, that's what they seem to think at the moment, that all the pain that you experience does come from in your head, but obviously you don't go and say that to people.
Well, it's always processed. Everything's processed by the nervous system.
Yeah, but that doesn't mean it's all in your head, because the nervous system is outside the brain. So it has.
Yeah, and it can be.
but the experience, so where it is, no. So if
You're wrong.
yeah.
Sorry. No.
So if you because you can have nociception travel all throughout your nervous system and have no pain at all.
So if it hasn't gone to that level, so it's initially picked up by your peripheral nervous system.
Yeah, neurons, spinal
which
cord.
travels to the spinal cord.
Yeah.
And it may not go up to, like, your spinal cord can make some decisions as well as about whether it goes to the brain or not.
Yeah.
So it might not go there if it doesn't think it's important enough.
Yeah, but if it doesn't go there, you won't have any pain.
Yeah.
So I'm saying that the pain experience has to be... But
there's a not recent, but there is some...
Recent.
So we have some notes here on phantom...
Wait. So are you saying it's not in the brain? Because it is. So what are you saying? It's in the nervous system.
Well, like, your nervous system isn't just your brain.
No, but you can have things travel in the nervous system. So if it gets to the spinal cord, you're not see what this seems to say to me is that if it gets to the spinal cord, you're not going to have any pain at all. Mm-hmm. It has to come from
it has to be
from the brain.
Yes.
Okay. Yeah, because we're going to talk about that in a second, how it all travels. Now, it probably sounds very, very simple, and I probably do have to say, which of course is obvious, we are not experts in any sense. We're just clinicians trying to make sense of this, and this is what the whole podcast is about. I think that it's important for anyone listening to this, and there's going to be people listening to this that are way more understanding, going, what the fuck are you guys saying? But this is how we understand it. This is from what we've read and what we're trying to make sense for other people, and I hope it is helpful for some people. I don't think anyone really truly understands it, but there are people out there, which we will put in the show notes, that understand it and can explain it a lot better than us. But you need to go out and, of course, look at this stuff and put some context to it.
Yeah.
Cool. You were going to kind of speak about... Oh, wait, before we get to phantom limb pain, can I kind of set a little bit of context for that?
Yeah.
So, sensory information or sensory cues, which is any information coming from your senses, such as vision or touch, need to be evaluated by your nervous system. Evaluation of these cues involves complex memory, reasoning, and emotional processes, and that must include consideration of the potential consequence of a response. The context of the pain experience is critical. Here is a simple example. Exactly the same minor finger injury will cause more pain in a professional violinist than a professional dancer, because finger damage poses a greater threat to the violinist. Now, that makes so much sense to me. I remember reading that and I hit you on the beach and said, hey, listen to this. Let me speak this out to you. Because I think, and then I thought, so for people so it's like their meaningful activity, because if you can't do something, it's going to be, if this injury or pain perhaps is going to be very limiting for what you enjoy, your meaningful activity, it is potential or has the potential to possibly be more sensitive or more painful, or the experience be more painful. What do you think of that?
Well, that's, because our emotions and feelings, they're all within our cup. Like, they're all factors that can contribute to our pain experience. So, of course, if it's something that's meaningful to you, then it's going to be much more impactful.
Well, I think it's like for runners, like if you were a swimmer and your femur got sore, I wonder how different it would have been compared to running, because you really enjoy running, you're good at running, it's a big part of your life, and it's the thing that has to stop you. I wonder if it would have been different because it's different context.
Yeah, maybe.
Yeah, I just thought that was interesting, and it makes sense for a violinist, and the reason is because obviously violinists...
I don't know if it would, I think it affects the response though, so it affects you in a different, well, maybe for me in particular. So let's say, like, when I first found out that I had a bone stress injury to my femur, my initial response was emotional, and it was confronting and overwhelming, and I think that probably didn't help the pain experience, rather than the pain experience being worse because of that. Do you know what I mean? Yeah.
And again, it's not to say that this happens every single time and someone comes like, oh yeah, it's just amplified because you love this and it's stopping you from... I'm not saying that at all. I'm just saying there are times when this is going to be more important, and it just exists on a spectrum like everything in healthcare does, but it's still interesting to...
And also maybe those people are more likely to ignore it and just endure the pain and push through it, which may be a good or a bad thing.
Yeah. So they talk about Some pain experiences include more tissue injury or disease than others, but there will always be varying emotional content. In pain experiences such as grief or rejection from a loved one, where there is high emotional content, like maybe when you rejected me when we first started dating. I don't know if you did. I don't know, but anyway.
I definitely did.
There will be still physical issues such as changes in muscle tension and altered cellular healing. In a situation where a man has had a work injury, say from lifting or falling, and his pain state is denied by a supervisor or a health professional, there may be a very strong emotional and physical component. The extent of emotional and physical components of pain experience clearly exist on a spectrum. Now, I thought this was interesting, and it's good to think about and potentially discuss. To effectively deal with pain, it is important to identify the contextual cues. We like to call them the cues that help ignite a pain experience, or ignition cues. And I had this conversation multiple times this week, trying to figure out and discuss with people, what makes it worse, what are you doing, where are you, and trying to at least speak about it openly. And it's not to say that we're going to say, don't do that, that's causing you pain, stop. It's just to getting to the point where you can potentially understand, why does that seem to make it sore or painful, how can we potentially modify or help, and then moving kind of forward from there.
Yeah, just like bringing their awareness to what their triggers are, I suppose.
So what do you, because I mean a lot of this research is done in back pain, what do you see as common cues? Is it just doing the movement again, or is it in a more environment, or is it doing the activity again?
When you say cues, do you mean what their
like
provocative things are?
Yeah, which they call ignition cues, provocative movement or provocative context.
Triggers, things like that.
Triggers, yeah.
I think it depends. I think like bending is not uncommon in back pain. People are fearful of that, especially if they've hurt themselves with a bending motion.
Yeah.
And I don't think that you can treat someone without addressing that. I think you need to bring their confidence back around bending, because it is an important movement that everyone needs to be able to do. I think people are aware of the fact that, well, in some cases, people are aware of the fact that stress and lack of sleep might be contributing to their painful experience as well.
I find multi-site pain to be a common one. If I'm seeing someone, which I obviously am, with lower limb pain and they have pain somewhere else, it's the one that is most common. They say, yeah, so I do this and then my shoulder or my back hurts and then my foot starts to hurt, and I'm not doing anything related to the foot. Like I might just be sitting and I'm doing something and my shoulder sore, my back sore, and then my foot starts to hurt. And it's interesting. I have found that if they make that connection or that link, it kind of gives it a little bit more evidence to say that perhaps it isn't related so much to what's happening on a...
Yeah, maybe it's more like your nervous system. It's just a little bit more heightened at the moment.
Yeah.
It's easier for things to become aware of potential threat, I suppose.
Yeah. So a lack of knowledge and understanding also creates its own inputs and increases fear. As an example, unexplained and ongoing pain and deep injuries that you can't see, unlike most skin injuries, increase the threat of pain. The more information that a patient has about a surgical procedure, an injury they have, even knowing that the pain after surgery is normal, the smaller amount of analgesics required and the length of hospital stay will be shorter, which is just like, that is, and that's an easy thing to do to help people understand that, but giving someone some education and advice and discussing it with them, like that is a really pretty easy thing to do.
Yeah, and it makes sense too, because our primal instinct is to treat things as if it's like worst case scenario, I suppose, like that fight or flight response. So if you're not sure about something, or you can't see it or visualize it or know what's going on, of course you're going to be thinking, this must be something really bad, because you want to try and help yourself as much as you can. So trying to, again, that's sort of explaining that in a way that is relevant to that person and making sense of their pain rather than just pain as a whole, so that they do have that understanding of what exactly is going on for them and their knee, and what that meniscus injury is going to mean for them, or whatever it might be.
Yeah. So we're going to have to turn this into part 1, because we've been going for a while, and we're going to do a part 2 next week. Now, I'm going to set the context for you right now. I'm going to ask you on air live to make a decision, and it's going to be to talk about that's what I kind of really excited, because that was really eye-opening for me, the sensors at the end of neurons and how stimuli travel the cord, brain, Or do we end it on phantom limb pain and then talk centers next week? Now, I know you're a little bit hungry, so I reckon you might choose the one that I'm not excited about.
The one where we talk about next week?
Oh, yeah. Which one do you want to talk about? Do you want to talk about next week? No way. We've got to talk about phantom limb pain, so I think that's really interesting.
I got to get this is the microwave.
The microwave's going. No. You can get it later. It'll be fine.
Put the fish in the oven.
All right, listeners. It is just me. Kelly has not returned, but I've got to give us some credit. It's very late at night, and Kelly very much is an early morning person, whereas I come alive about 8 p.m. I reckon I'm most productive between 8 and 11. So we'll finish it there. And next week we wanted to talk about phantom limb pain, definitely, which is really interesting, and the homunculus and the concept of smudging. And then also about how our nervous system basically moves stimuli from the spinal cord. So as a kind of brief introduction, you've got a neuron. On the end of the neuron, you've got a sensor, and you have sensors for many different stimuli, mechanical, chemical, temperature, that kind of thing. And over time, if it's continued to stimulate, it can reproduce and then become more sensitive, and then that can also happen in the spinal cord and the brain. It's really, really interesting, and it gives you a lot of context to the hypersensitivity and the allodynia, how people can, originally with an injury, it's only a couple of things we can work out that make them sore and more uncomfortable, but over time it becomes more things, and then things that aren't usually sore can make it worse. And that's where I think it's important for us to understand that, a lot of the things that we do potentially aren't going to have as much of an effect as what we think. And we, as an example, back to what we talked about at the start of the podcast, someone with lateral foot pain making a wedge, it's all the chance that the wedge and the pressure and the sensitivity around the nervous system and the neuron to that orthoses or that wedge or that shoe can make things worse. And it's just, something to be understandable and to try and, it just gives you a little bit more context and a little bit more humility. We wanted to talk about peripheral nerve problems, and one of the things that was, I reckon it was probably the most I'd read about peripheral nerve injuries in a long time, and a lot of the conditions, I think especially with plantar heel pain, a lot of acute traumatic injuries where, we're thinking tissue or ligament or joint, where it's probably something peripheral nerve related, and how long they take to heal, and then when they change and heal, what that can possibly mean. And they do change, or the sensors basically reproduce every 2 to 3 days. So that can be awesome for patients to understand, because that can mean that their pain may be changeable in the future and all these kind of things. It's really, really cool. So we'll speak about that next week, and have a lovely week.